this being an important health indicator, especially for the states of both Bihar and Jharkhand. Now, since the onset of the COVID-19 pandemic in India, Dr. Narottam has been supporting the NRLM mission in both Bihar Rural Livelihood Promotion Society in large scale, and also with the whole COVID-19 awareness activities. So welcome, Dr. Narottam Pradhan, and thank you for your time as a panelist. So, Dr. Santosh, shall we get straight into the presentations? Is that okay? Or
yeah, that's fine. I think let's do one by one.
So, Dr. Narottam, may I hand over the platform to you, sir?
Thank you so much, Dr. Santosh, Dr. Priya, and all my colleagues. And it's a privilege for me to be a part of this. And I'm privileged to share a few of my thoughts with my colleagues from both Aruka Network and CMAI. So if I may just share my presentation, it always helps to have an organized way of speaking, so to say. So, I'll be brief given the time that we have in hand. And here am I, and maybe we can take some questions later. So, being from the community medicine specialty, it's always better to have some kind of empirical information at hand, when you speak about what's happening in the field. So I'll largely be speaking about rural Bihar because that's where we're working. What I'm presenting is we have a small concurrent measuring and measurement and learning team with about 26 telecallers, and we've got about 9 lakh SAG numbers. And, we do a systematic sampling of these numbers and trying to make, district representations, and in fact, 35 of them. And then, we kind of contact them for different reasons, and this one in particular is during the height of the COVID second surge, somewhere around 25th of May to 8th June. And what I'm going to speak is based both on this, information that we have collected, basically on behalf of Divika. And also, we have some field team who continue to give us insights of what's really happening there, So it's based on both of this a bit. So let me just look at some of the areas that I'll cover. We're looking at COVID awareness and appropriate behaviors. We're looking at COVID infection when it really took place. I'm thankful that, the surge came fast and it left fast. I mean, within a couple of months, it began and it was over. And that is the only good thing about it, I feel, but I think all of us have been impacted somehow or the other, in our families, amongst our friends, amongst our colleagues, and we know how hard it has hit us. But I'm also going to share in terms of rural population of Bihar, how it has hit them. And of course, a little bit of the resilience and the response, and a bit on the post-COVID scenario. I'm not saying COVID has ended. When I say post-COVID scenario, I mean those who got hospitalized due to COVID, what about them? So these are the topics I'm going to cover. And, let's look at, awareness. And as I, in my introduction, you spoke, there was about how I've been working with the Livelihoods Mission, doing virtual, trainings, 30, 40, 50,000 people at a time, from Delhi, from Bihar, and a cascade training reaching almost to the villages. And we were hopeful that at least apart from, of course, TV is the main source of information, but some of these trainings have also helped them to understand what the COVID disease is. So, you can see it, knowledge is almost universal, at least about 96% knowing that COVID is an infection with fever, cough, cold, and breathing problems. The other signs and symptoms are a little less known, and how to prevent it, using masks and staying at home and hand hygiene, respiratory hygiene, social distances. There is this whole variation in knowledge as well as information. So what would I say? I would say that there is a widespread awareness of COVID in the community, but there are specifics of this disease presentation, maybe not widely known. Also, COVID appropriate behaviors are not practiced widely. Although people do say, I know what to do, but there is a kind of waxing and waning of preventive habits. We know that the second surge, where government actually had lockdowns, the behaviors were more practiced, but, as we have seen or are seeing now, the behaviors are not really long lasting, and it's very easy to drop habits like social distancing, not having social gatherings, and not wearing masks. And these are things that we are seeing. But of course, it was heightened during the whole surge. So let me look at, how did we see uh, how much of rural population of Bihar got, affected by this. Although we, as Priya said, in the urban areas, the bigger cities, the tier 1, 2, 3 towns, we've seen that, in fact, in my office, about 80 staff, I think 70%, 70 of them were either infected or their family members infected. So that's a very high rate. But in the rural area, when we asked the women, it's about 1/5 of them, said that someone or the other in their house has some signs of symptoms. But of that, only 1/4 actually got tested for COVID. Many of them had mild symptoms. Many of them had the fear that if we get a positive diagnosis, then we may have a social stigma around that. So I think largely people didn't get tested. The 1/4 or 1/5. So like the numbers are. And of course the response was mostly from the local, I'm calling practitioner, but these are basically the rural medical, practitioner, kindly said, or quacks if you would like to. And few of them taking help from the local pharmacy, and very, very, very few of them visiting any hospitals. And so this is the kind of scenario we saw. Mostly, when the vaccination program started, by now 1/4 of the members said they have one dose. 2/4 are saying that we are still wanting to take the vaccine, and I think there is some amount of hesitancy. 1/4 are saying that they will not take the vaccine. Either they don't feel the need or they fear the side effects. And this is what I have just shared. So I'll go quickly. And now, how has it impacted the livelihoods? Our data says that 1/3 of the rural households have been impacted by the COVID surge. And almost like 71%, had to either eat on their savings or take loans. And you can look at it, and this is what we saw, that most of the rural population, had to take loans. And, there were no earning members, even in 1/3 of the households that we saw. But then women actually took up more of livelihoods, more of domestic work, and men actually were less occupied during the second COVID surge. So of course there is a lot of difference through the COVID period, but basically I'm focusing on the second surge. So what has happened? There's a lot of resilience in the rural families, and as I said, it came fast, it left fast. So the punch was hard, but it was not long lasting, and many families actually did not have severe infections, and they recovered very fast. What we do understand from the villages, from our local, network, is that there were many villages which saw more than average deaths and diseases during the months of May and June. And so there were deaths there. By and large, people just went through the disease and they recovered. A lot of interventions were taking place where there is organized, community. So I'm not talking about isolated community, but Jivika actually organizes the community through its SHG, and there is over 10 lakh SHGs even now in Bihar. And they actually did a very, very intensive, ration card enrollment, and 17 lakh new ration cards they ensured were given. And I'm given to understand that 96 of the rural population actually received ration on discounted rates from PDS shops. There were these vulnerable families who were given cash transfers and interest-free loans. The things like what's called a food security fund, health risk fund. We also understand in some places community kitchens were organized. Some places, people actually, the community didis made food and reached into the household where everyone is infected. And they also, we are very familiar in Christian circles of Ek Mutti Anaj, and this was also, I believe, practiced in Bihar. And wherever there were migrant returnees, some small business and enterprises were enabled. A very interesting thing happened on a small scale, though, because the government realized that some of these quacks may not be giving the right medical advice. Jivika teamed up with an agency who actually developed an app and had a whole panel of doctors behind them, and they could be reached out who gave them right advice. I'm actually also looking at CMAI, if they can have a whole panel of doctors and maybe through an app, give back-end support to some of the telecounseling. We are already talking to AIMS Delhi and AIMS Patna. But the more the doctors we have to reach this 10 lakh plus SHG groups and their families, which is over 1 crore, in case of any emergencies like that, this could be something that is very interesting that comes up. So this is what I'm saying, but we've also heard a lot of cases, which is not in the report here, of cases of social stigma and social isolation. When someone got infected, got positive, literally there was no one to help them, even with the food and medicines. We have heard that many times. It's not in the data set, but it's been reported. We have spoken to certain ladies who faced this social stigma. Someone in their family died, no one was there to help them. Go to the hospital, no one was there to even get rations. And there were cases when there was no one to even, cremate or give last rites to the dead. Now we have a small team of about 40 persons who we are working with on a telecall, for post-COVID patients. So government of Bihar gives us all those numbers of those people who are hospitalized in government hospitals. And we reach out to these telecallers to give them, psychological and medical advice. And
it's
we
part of
are seeing
Arupa Foundation.
Yeah.
Arupa is like a thing of.
Yeah, we are seeing a lot of, health, psychological, and social problems, which is post-COVID. So I'm very brief. I think that's the amount of time I had. So I don't want to kind of go on and on. But this is just a snapshot of what we have observed from Bihar, rural areas during the COVID second surge. Thanks a lot.
Thank you so much, Dr. Narottam. I think you brought a fantastic, holistic overview, which only a community medicine specialist can bring. And that is the beauty that our line of specialty brings to this whole world of medicine. And thank you very much for the fact that you're looking at the resilience. You touched upon important factors that even though the punch was hard, it was not long lasting. I think that is something that is actually can be a building block for us to take forward. So as we look at another speaker who will now talk about another aspect of the community response or the community impact of COVID-19, may I request for the next speaker's introduction to be put up, please? And this doctor is from one of the largest NGOs in our country, World Vision India. And Ms. S. Divya Shafila is the Associate Director for World Vision India. Of course, it is known as, all of us know it as a child-focused organization. She provides the leadership, the development program for Bihar and Jharkhand. She has worked on public health issues, water and soil conservation, economic development, and disaster management in India, as well as the South Asian countries. Ms. Divya, it's really a privilege to have you, and we will hand over this next few minutes to you.
Thank you, Dr. Priya, for that introduction. And I want to thank Aruka Network and CMAI to be organizing this. And as I was preparing for this, it was a time of self-reflection as well to see, what we have learned from Wave 2. And truly, as Dr. Narottam has said, it has brought a lot of learnings. It brought its own set of surprises, but I think in many senses, some of the resilience building also we have seen from the learnings of Wave 1 as well. So today I'm bringing to you the perspective of the same from a social worker's point of view, and from our experiences in the rural communities and urban communities of Bihar. Let me share my screen with you. Okay, I think some of the points have been covered by Dr. Narottam, so I'll try to skip those. But I think Bihar is quite unique in the sense that When I recently moved to Bihar, I was based in Ranchi, and when I came to Bihar in February, and in March, the second wave had slowly started. For me, the one of the biggest surprise was the COVID appropriate behaviors. Wherever I went, I saw many people without mask and improper mask etiquette. Even if the few people who had the masks on, it was either under the chin or hanging around the ears and not really covering their nose and mouth. And everywhere I had to, everywhere I went, I had to go on educating. So it was quite a surprise for me that in Bihar and social distancing was also not followed. And I had a couple of conversations with people either on the street or people that I was working with. And one attitude that really came out, on one side, if you look at it positively, it is a good confidence, but you cannot have confidence with, facts like this is an infection that would pass on if you do not take, if you do not follow the COVID appropriate behaviors. One thing that everyone in Bihar was very confident, particularly in rural areas, because I did a little bit of traveling too, was that, COVID will not harm us. We won't get infections like COVID. COVID hame kuch nahi karega. That was the attitude. And breaking that attitude is really very difficult. And I think the wave 2 kind of got so much of attention of everyone that, within a month, I saw the change in attitudes and everybody started wearing the mask. And there was so much of information explosion as well in the media in different forms. Which led to panic, which led to a kind of scare, a COVID scare. And some have actually taken it too much too hard. So this has impacted the COVID appropriate behaviors as well. Just coming to quickly, the health seeking behavior. This is a huge gap we see not just in Bihar, but I think also in the rest of the country. On the lack of knowledge of medical services. In case there are symptoms, they do not know where exactly to go to. And we have seen many people having self-medication because of the information that they got over the social media, and they went for over-the-counter medication. In rural areas, rather than going to certified practitioners, the preference was going to quacks, which was a very difficult thing to break. And because of, again, coming back to the point of the social media, information, there was a lot of panic over mild symptoms also, and they were rushing to the hospitals, creating a crisis in the medical field itself. Because of that, which there was unavailability of beds and oxygen cylinders. We have heard various reports where people who did not have severe symptoms were actually occupying the beds, and those with mild symptoms were occupying the beds, whereas the ones with severe symptoms were not able to get. And there were instances where people were rushing from one hospital to another hospital in search of a bed. There was also panic purchases of medicines like vitamin C, zinc, vitamin D, and other COVID-related medicines as well, that the medical, I remember once going to a medical store for a vitamin C, and it was being rationed out to all those who came to purchase, because they had run out of such medicines as well. So this was again a behavior that was seen during the second wave. Also, there were lack of knowledge on post-COVID follow-up. There were some sudden deaths that we have observed, which is again because there was no knowledge on post-COVID follow-up. Everybody would relax after they became negative and then go ahead. But the issues like the medical health conditions like thrombosis and all had come up. We also know about the black fungus, which was followed up. So the post-COVID care and follow-up was something that we saw was lacking, in the wave 2. And a lot of general health services had taken a break. They had taken a hit, like essential services at the PHC, like vaccination, the ANC and PNC check for pregnant women, they were hampered. Anganwadi centers were closed down, and this affected the nutrition status of children and pregnant women a lot. Some places the take-home ration was distributed. Some places it was given. We had done a gap analysis. That was one service, probably to a large extent it was done in every place, but all the other services had actually taken a hit. And in this COVID crisis, the treatment of other ailments took a backseat. And this we saw it not just in the public, but even with our own staff. That somebody who was diabetic did not go for a check because they were scared of going to the hospital. Somebody who had high blood pressure, they were still suffering at home. Or any other ailments that they had, they all took a backseat because they thought this is not the right time to go to a hospital, because hospitals themselves were also, one of the spreading places. And we also saw that urban transmission was high and rurals was less, but comparing to the first wave, the rural transmission also had happened, though in a smaller version. And I think the statistics that Dr. Narottam had shared support that. Looking at the social impact, there were a lot of myths and misconceptions around vaccination. And in some of the places where when the district administration had taken vaccination, to the village level, there were people running away because misconceptions like it increases impotency, it influences the fertility, or it causes death. And also the side effects was something that everybody was scared of. So that had led to, the vaccine hesitancy. And there was limited access to vaccination also. There was no production of so much of vaccines as the demand is. And so there was limited access, and vaccine centers in urban areas themselves became the spreading grounds. I have a personal experience in this. My father, who went for his second shot, he actually came back infected because he did not have any other exposure from that time. And yes, those became spreading grounds. And there was a lot of COVID illiteracy at various levels because there were designated hospitals, but people did not know they would go to any hospital. There were insurances which people were not aware of. The transportation system that was there, people did not know how to take them. And Dr. Narottam also pointed out about the social stigma. The social stigma toward those who are COVID infected and affected, people would not want to go closer to them. Now, this also impacted, the social stigma also impacted in people coming out and getting tested. So in particularly in the rural areas, we observed this, that because of the social stigma they were facing there, they were not even ready to come and get tested. So many people did not get the treatment right at the earlier stages, and till it got worse, they wouldn't come out to get treated as well. And as we all know, due to the lockdown, there was a loss of livelihood which led to food insecurity. But I think this time the families were better equipped because they have seen this earlier, and we did not have severe reports of food insecurity. Of course, the PDS system was working. There was a reduced intake of vegetables as such that got reports from the rural areas, but they were able to manage better than the first wave. But there was still, food insecurity in the rural areas. There was a lot of out-of-pocket spending, a drain on the financial resources, and particularly in the communities, there were many of them for getting themselves treated, they had to get into debts. And also ultimately, on the larger scale, I would say it has a drain on the GDP, which will affect, our government policies and schemes in the future, because with government not having revenues much, this will impact our economy on a larger scale. We also looked at, the household preparedness during this pandemic. Before that, I think a couple of things that we really need to look at is that going forward, we know these waves are going to come and go till the 80% of the population is fully vaccinated. And particularly those who are not vaccinated and children in the age group of 12 to 18 years are at high risk. Children below 12, to medical reasons, which I think many of the medical professionals are here. They would know why below 12, children will not get affected, but they could be carriers. So we have to be careful about that as well. Currently we are at 4.9% fully vaccinated, and 21%, with the first dose that we have covered. So there has to be an increased vaccination. If at least one person in the family needs to be equipped with the COVID response, because if there is COVID illiteracy, at every level, then there will be panic again. But if at least one person in the family is equipped with this response, if we can all ensure that, then I think they would be able to handle it better. The key to all of this is the early detection and treatment, and this can happen only if, again, the social stigma comes down and there are more linkages for early detection, increased testing. And also home-based care for mild symptoms, because we've seen the panic even for mild symptoms. So home-based care should be taught for mild symptoms and treating at home itself. And also I know the prediction from some of the experts is that it will be infect the children mostly, but everyone who's not vaccinated is equally at risk. So for childcare and for mild symptoms, a home-based care at the household level would increase the resilience. Looking at community level, I think there should be a strong community-based tracing and testing of symptomatic population. And the current resource that we have are the Anganwadi workers and ASHA workers who can be used for this, because it being a pandemic, our existing, medical personnel that we have is not enough. And in a rural context, most of them stay in close quarters, be it a single family, or most of them are undivided families. So that becomes very difficult for them to have home isolation. Wherever possible, that can happen. But at the community level, isolation centers need to be created so that the community can be prepared, and those who are tested positive can actually be there and get treated. Increased vaccine acceptance has to happen, and also increased access. For this, I think all the block, district and state and central governments are taking all measures to create this awareness. And I still think in spite of that, there is still a need for awareness creation so that there is more of vaccine acceptance. Thankfully now COVID registration is not always necessary. There is on-the-spot registration as well. So this is a blessing. Attaining vaccine equity, this is where the government, the CSO and the community has to collaborate and come together. But more importantly, I think the availability of the vaccine is very important, which the government has to ensure currently. And a huge role, I think, will be played by the faith leaders. We have been engaging with faith leaders of different faiths and helping them, understand the importance of vaccine, and asking them to go into the communities and increase their vaccine acceptance. Since they have a huge influence in their communities, they could be a very good way of approaching the communities and influencing them for vaccine acceptance. And not just that, faith leaders also can play a huge role in stopping the spread. Because many of the people have got infected after they attended funerals or weddings, and they came back and tested positive. So to streamline those and to aware the community and restrict such kind of gatherings, I think faith leaders can play a huge role. Finally, how do we build back better at a macro scale? I think the increased access to a lot of social safety net programs that the government has, these need to be done. One thing that in wave one itself was started by different governments was the cash transfer. I think I will not elaborate much on the others since we all know about that, but cash transfer gives a lot of choice for the beneficiary. Like I said, PDS did give them the grains, but cash transfer gave them the option of choosing what to purchase, because some of them purchased vegetables, somebody paid rent of their houses, somebody paid internet facilities on their phone because their children had to. So these are the various ways, and we have seen that firsthand, that cash transfer actually helped out many people, because some of them also have used it to purchase grocery items which they could sell and try to have an alternative livelihood through cash transfer. So the social safety net programs access should be increased. And also, since this is a new normal, our essential services should continue, because these waves are going to continue, and we cannot stop these essential services, and they need to continue like routine immunization, because there's a window of opportunity for every child. And within that window, they need to be immunized. Otherwise, it does not have a huge impact. So these regular services should continue, like growth monitoring of children. The take-home ration should continue. And now the vaccination, the studies have said that vaccination for pregnant women and lactating mothers is also okay. We need to ensure vaccination for them, and proper nutrition is given to them. NRC should be equipped with COVID isolation, because some of the mothers who take their children also could be COVID infected, but yet, it is always a difficult choice that they have to make. Should I take my child to NRC or at home isolation? So for that, NRC should be equipped to handle that. And adolescent girls need to have continued access to IFA, sanitary napkins, and life skills, which has completely stopped during this time. Protection mechanisms for children need to be really strengthened, because even during wave 1 and wave 2, we have seen that children have suffered a lot. There has been increase in violence, physical violence, domestic violence at the homes. And children have gone through a lot of psychological issues. We have been working on this with Sphere and even Central Institute of Psychiatry in Ranchi. And recently we did a pilot in the district of Dumka in Jharkhand, and we found, through volunteers, we found that 46 children, in a matter of a week, we identified them that they need intervention, either home-based intervention or institutional intervention. So it's a complete generation that we are looking at, who is going through this. And as I said, the regular systems like home-based learning systems should be encouraged, should be brought up for children, because now with the new normal, we cannot expect the schools to be open very soon. Right now, even only for the high school that is opened. But for other children, some of the children probably don't even know what going to school is, because they stepped into a COVID infected world, and children who are 6 and 7 years old, they don't even know what it is to go to school in our communities. So to build back better, I think we need to look at all of these areas at a macro level and ensure, because we were trying out various things, but unless the government comes back with a curriculum or a stronger protection mechanism for children, it is difficult to, just for few NGOs or a few institutions to work on it. So at a macro level, these are the things that we could look at. And I think at the end, I would like to conclude by saying that, the learnings from wave 2 should equip us better for wave 3, the way wave 1 experience had prepared us for wave 2, though it had its own set of surprises. So going forward, I'm hoping the resilience or at every level, at the household level, at the community, and at the larger society, we would be able to build. Thank you.
Thank you very much, Ms. Divya. Again, another brilliant presentation, giving us an overview, which I really liked in terms of the the pandemic preparedness, as well as the post-COVID scenario management. Dr. Narottam talked about a helpline, which could be of use, and you've also brought about post-COVID complications, care, and follow-up. I'm setting the stage for the other other speakers who are coming from the medical aspects, because they are our continuum of care from the community to the hospital. Another thing, important things that you've brought up is the fact that the government has got a lot of the social safety nets in place, but access to it is definitely the role of our community health workers and for us who are working as frontline workers there. Yes, a lot of issues to bring up in building back and definitely something we can take forward. So thank you very much for that presentation. And as we look at, first we will hear from Dr. Ashish to get a community health program which is being managed from a hospital in a small remote part of Bihar in Madhepura. And after he gives us his presentation, which I'm quite excited to listen to, we can have a few questions. There are already 2 in the chat box. And if the panelists would be able to answer it on the chat, that would be perfect. Okay, we can also have a short discussion before we move on to the next medical aspects of the COVID-19. So to introduce Dr. Ashish Abraham, he is the Community Health Director of Madhepura Christian Hospital, and he's also the nodal officer dedicated for the dedicated COVID Health Center, which is the MCH, the level 2 care as per the government classification. So over to you, Dr. Ashish.
Good evening, everyone. It was really good to hear, as Dr. Narottam and Divya have shared before me. And being part of a hospital, it gives a better chance to be part of both the hospital aspect and the hospital response, as well as the community response to the COVID wave which we had. And I'll share my presentation with you. So the pandemic lessons that we have taken from this COVID pandemic that has swept the whole of our nation. And as Albert Einstein has rightly pointed out, the more I learn, the more I realize how much I don't know. So even after the first wave, a lot of people thought that we have learned a lot about COVID, how the virus is spreading, and what all measures we should take. But when the second wave hit us, we eventually realized, there was much that we had not known about this disease. And that was one thing that caused a major, outbreak of this disease. So as we look forward, the one thing I think that we all have learned, especially in Bihar, is that COVID is not scared of Bihar. Actually, that's one of the lessons that we learned, because when whole of India was, running helter-skelter with cases rising, and Madhepura, a rural part of Bihar, and we were not much affected here. Even the first wave did not have a much impact. And so we were a bit relaxed that this time also it won't affect us in that way. In fact, the entire state of Bihar was in the same relaxed mode, that this disease is not going to affect us in a bigger way. But I think that misconception and that myth was at largely shown to us that it's not like that. And we had a lot of cases this time as the COVID second wave affected us. So as I share this presentation, I would be taking it in 2 aspects. One is the hospital and the community response that Madhepura Christian Hospital. It's a mission hospital, 100-bedded hospital here in Madhepura. And I would be concentrating on both the aspects which we had during the COVID wave, as well as then I'll be looking at the lessons that we learn and how we are preparing if in case there is a wave ahead of us. So as I said, our mission hospital is a 100-bedded small hospital. And when we faced this wave, it was like, God has called us to be the light in the darkness. So when we looked around, our district has a medical college as well as a government hospital. But still, we were getting a lot of cases referred to our hospital. So eventually, we decided that we should apply, and we requested the government to allow us to take patients, and we were allowed. Finally, we were made as a dedicated COVID health center. of 50 bedded, and we were allowed testing as well as admission of COVID patients. So I'd like to put forward the transformation. This was our community training center. And as you can see, we had trainings as well as we had our morning devotions being placed in this center. But as soon as the wave hit us, before that, we just converted that training center, community training center, into a COVID hospital. And we had a full-fledged hospital with a ward, ICU, as well as the major thing that we did was we had a labor room and operations that we had. So this was a main aspect because a lot of patients were denied surgeries if they were COVID positive, but we could get a lot of patients and operate on them and conduct procedures. So this is a brief view of the patients that we had. We had around 400 patients that we tested. We had 90 inpatients, both in our ICU as well as ward, which were moderate to severe COVID pneumonia, and all of them required oxygen. And we had almost around 30 patients, more than 30 patients who needed ventilator support, non-invasive as well as invasive. Then apart from these, we also had patients who were sent for home quarantine, whom we had seen here and advised home quarantine. And by the grace of God, we had a good recovery rate. Almost 75 of our admitted patients recovered. We had a maximum length of stay for 44 days. We had a mother and a son who were admitted, and they had very severe CT severity scores, which I have mentioned here, and deaths. Yes, that was a very difficult part and a challenging part, which all of us had to face during this pandemic. We had 15 deaths, out of which some of them were on arrival. And so effectively, we had some 10 deaths, which patients had stayed and then they expired here. And as I mentioned, that surgeries was a very important part because we got a lot of referrals of patients, especially women in labor who were denied admissions elsewhere, and we could conduct cesareans here. And we had some 10 babies who were delivered here. And we had 3 peritoneal dialysis. Since we did not have we could not send the acute kidney injury patients outside, we had to do peritoneal dialysis, and we had 3 patients on peritoneal dialysis at our place. Next is our community response. So this was also a major area, being a hospital which is swelling a lot into community, and we have a lot of villages, 14 project villages, which we are covering, and our community health team, community health and development team is doing a transformational work here, and our project manager involved in this, he has done a great job along with the team. There were health camps during this pandemic period, which we conducted for the people who were not able to access healthcare. Livelihood supports, we were continuing to provide livelihood supports. As you can see, there were some 260 farmer families which we provided support. Also, we have the milk cooperatives whom we are assisting. Then the care for elderly, we had some blanket distributions during the winter season. But one important aspect here, which I want to point out, is the cash for work. It was a highlight. Cash for work, and this was transformational in the way because we provided them work for the communities, such as building the roads in the communities, the embankments, as Madhepura is a flood prone area, so we used embankments, we repaired the embankments, and we used the workers from the villages, provided them the work there, the repair.
We are losing audio, Dr. Ashish. You want to turn off your video? Dr. Ashish.
There are stories and testimonies which people have said that because of this money which they got during this lockdown period.
Dr. Ashish, sorry to interrupt you. Can you just switch off your video? We're losing your audio in between.
Okay, sure.
Yeah, thank you.
Yeah.
Yes, Dr. Ashish, go ahead, please.
Yeah, am I audible now?
Yes, yes, perfect. Thank you.
So as I was saying, cash for work. So this was transformational for the families, and we gave them projects from their village itself, like repair of the roads, building new roads, canal repairs, repair of the embankments, and which provided them livelihood support and also cash which they could use during this lockdown period.
I think we have lost.
Dr. Ashish, we're not able to hear you.
Yeah, am I audible now?
Yes, 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 now you are. Yes, go ahead, please.
Yeah, so moving forward, the lessons that we have learned from this pandemic and the way forward. So one of the things that we had in our hospital, the COVID center, was oxygen. So oxygen was one of the rate limiting factors for us, which decided our admissions, which decided how many patients we had to keep. And it was really some sleepless nights we had, because when we would know that there were only 2 cylinders and we had patients on 16, 20 patients on oxygen, but God amazingly provided during all this time. So we decided to get an oxygen plant, and by the grace of God, just 2 days back, our oxygen plant has arrived, and that would be a very inspiring. That has really helped us. That will really help us if there is another wave to combat the COVID cases. The next thing was the investment that we did in the critical care equipment. We realized that during this point, we had a lot of sick patients coming in our hospital, and critical care was the thing to go ahead. So we made a lot of investment in the critical care equipments, and which I believe we will be able to use in case there is another wave. Next thing is what we planned was for dialysis. Dialysis is we had to refer a lot of patients with acute kidney injury. So we decided that we would have dialysis unit, and we are planning on it so that in case there is a wave, we would be able to treat the patients who are especially in the acute phase of renal failure. And the last one was the mental health of staff. We realized it was a very challenging task, daunting task, especially to help our staff who were working in the COVID area. And with all the things happening there, they were stressed. So we had regular meetings with them over Zoom, over even meeting them in person, and regular debriefing with them, which would help them, give them support. And that has helped us. And we plan to do it in the days to come too. In the community side, the lessons that we have learned is, the first one is that rural population is not spared. It was a misconception that the people in the villages are not affected much, but this is a patient which we had. He came from one of our villages. He had 96% of lung involvement. His COVID CT severity score was 24 on 25, and he stayed here for 21 days. But by the grace of God, he recovered fully and was discharged. So we got a lot of patients from the villages. So it was not that only the patients from the town or from the cities were affected. We had patients who were coming in from the villages. Second was that rural people are not aware. This even now we are witnessing, as soon as the lockdown is over, it's a very distressful sight in the town, in the villages. People are not wearing the mask at all. There is no kind of social distancing. The shops are all have opened. So it is it's very distressful to see, especially when we see so many sick patients, and it's difficult to make them understand what we are seeing. The last is rural people do not care. And one of the reasons for this is a story of a woman from a village, which says that during the lockdown, she did not have food to eat. And that is one of the reasons. She said that I will die before of hunger rather than of COVID. And it was a very heart-wrenching moment when we heard her story, because it's actually true. Health is not a priority. COVID is not a priority for them. When they looked at lockdown, when they looked at how they are suffering, it's what they need. That is one reason why they are not bothered about how big this pandemic is or how it is affecting it. For them, what their basic amenities are, what their basic necessities are more important. So a lot of measures that we have taken. First is the follow-up of the post-COVID patients in the community. Then we had the community awareness. Then one of the major features is early identification of the patients. Next is accessible healthcare. And finally, we have the livelihood support. I will be briefly sharing about all these. So the major important thing was follow-up of post-COVID patients in the community. This we have taken up as a team. We are going and visiting our patients who have recovered. Some of them are still on oxygen, requiring oxygen. And one of the things that we found is they are still reluctant, as was shared earlier, mucormycosis and post-COVID complications. A lot of these things were happening. So we had to educate them about how to control the sugars. So one of the families that we visited, they did not turn up for a follow-up at the hospital. So when we went to their home and we convinced them somehow that their sugars were not controlled and they should come and visit, and we will help them to control the sugars. And what we saw was a good result. The next week, we saw them coming into the OPD and we could treat them and we could help them control the sugars. So it was a very good thing that we found. It sounds crazy to visit, each family and going to their house and talking to them, but we found good results with this. The next is a community awareness. Our community team has been doing a great job going from house to house, collecting people and trying to educate them, about how this disease spreads. And I know it is very difficult, even when they are teaching them. Some of them come without masks, some of them come, they will be sitting together. But in some little way, we are able to share with them what this disease looks like, what is an influenza-like illness, what are the symptoms, how can they be isolated at home, what can they do. And this is a small picture. We were planning to do it in the schools, but since the schools were closed, so the neighborhood children were gathered and they were taught how to wash hands. So this things is a big campaign that as a community team we have been doing, and we have seen good results with that. And it has been a good initiative from the community team here. Next is we have planned on early identification. So what we decided after the second wave was we decided that in our villages, there should be no deaths because of COVID. In case a COVID third wave hits us, we are trying to prepare for it. And one of the things that we have done is we are forming village health surveillance teams. So we want to identify if there is any case at the earliest, because during this COVID wave, we had a lot of late presentations where patients came to us after 10 days, 20 days at being at home or being at some other center, not knowing what they had to do. So this time we decided to inform them, to educate them about what are the early symptoms, what are the symptoms of influenza-like illness. And we have, as you can see here, we have a manual printed where we have selected volunteers from the village itself whom we are training. And we are making teams of 5 people in a village who will go and who will educate the people and who will also do screening. We are using infrared thermometers, also pulse oximeter, to screen the people, and also then we are promoting quarantine for them. So quarantine, we have home quarantine as well as institutional quarantine for these people. And the loss of income that they have, we are trying to support them for that also, so that people will be encouraged that they could come and they could be quarantined, they could be isolated if they have symptoms. Also, we are also training these people to refer the patients to higher center, to a government institution or to our hospital if they have moderate to severe illness. We are telling them what are the signs of it, how can they know about it. So all these trainings are being given at the community level to these people. Next is we understood that a lot of diseases, patients were not able to access healthcare during this COVID time because of lockdown. There was no transportation available. People were not able to get out of their houses. So we decided to reach out to them. So one area was village health camps. So we have taken up very seriously post-COVID time. In this past 3 months, we have seen around 450 to 500 patients in our village health camps. Next is home visit. As Ms. Divya was sharing, that a lot of patients who cannot come, who cannot reach out. So as you can see, mental health is one issue where they are not bringing the patients here. The fear of COVID. So we are visiting these patients at their home, palliative care, disability. We have a team of occupational therapists, physiotherapists. We are taking them, visiting these people at their home, and trying to give them the care that they need at their home. So it's a major task, but we are trying to do it and reaching the villages where we can. And the next, as was shared earlier, also telemedicine. This is like a groundbreaking thing if we can do it. And we have a pilot project with 5 centers now. We are developing it, and this is to provide daily OPD services for the patients from the villages. So we are trying to do this through teleconsultation. We have set up centers in the villages where the patients there can access healthcare through teleconsultations with our hospital. We will be having a doctor who will be available for teleconsultation, and we will be reaching out to the patients there in the villages. So we are hoping that this will be a way forward. Even if the third wave strikes us, we will be able to reach out to the patients. Next is the livelihood support, community and livelihood support. We have been doing that during the wave also, and post-COVID also. We have been trying to, provide livelihood support to the people of our community in the form of we have goat rearing. Also, we have been providing seeds. We have a scientific society agricultural center here. With the help of that, we have been, connecting the villagers, the farmers, with these, with all the programs and all the new techniques that are available, so that they can be benefited to that. And we are also doing the Zoom meetings with them. And in one of the pictures, we can see there was a fire outbreak in one of our villages. And one lesson we learned was during that moment, how to, help them, because it was a lockdown state. There was no one available to help them, but we could reach out to them. So even with the lockdown, with this pandemic, there are other disasters, other natural disasters that can happen in the community. And how we can approach them, how we can help them in those situations was also one key area that we learned during this pandemic. And the last one is a picture of a house that we helped to build. And this is also one area, because of the constant rains here and the houses that are, this lady, she had a whole crumbled house. But as a community response, we were able to help her and build this house. And the last, finally, was the vaccination challenge. As we all know, and we have also read in the news about the Musahars, the Mahadalits. It's basically one area that we are working, our community team is working. They are very reluctant for vaccination. We have talked to them, and there is a myth, there's a misconception that if they take the vaccination, they will die. So it is a very challenging task to convince them. And for us also, even when we organize the health camps, we are not able to get patients to our health camps because they think we have come to vaccinate them. So we are trying to, rule over this myth, this misinformation that is going around in the villages. It's very difficult, but what we have decided as a team is we are choosing the leaders from the villages, like the CBO leaders, also the village leaders, the elders. We are choosing them so that we could set them as examples. We are helping them. We are convincing them for vaccination. So once these people, these leaders get vaccinated, they can convince the others to follow them. So this is a major challenge that we have now, and we are trying to overcome it. And as all of us have shared, it will take some time, but I believe that with the proper awareness, proper education, we will be able to overcome this vaccination challenge that we have ahead of us. So yeah, that was basically from our side, from Madhepura. And that as a community team, we have been trying to reach out to people, to make them aware of what this pandemic can cause, and at the same time help them at the grassroots level, to sustain their livelihood. Thank you.
Thank you so much, Dr. Ashish. Again, an excellent example of how the community health department in a hospital can repurpose and revision their whole activities to support their hospital services, both at the hospital level as well as at the community level, and giving that perfect continuum of care. Really good example of the village health surveillance team. And I'm sure, like you've already said in your presentation, you'll be looking at chronic diseases also, because many of our programs have now been set back by almost a decade because of the pandemic and its lockdown effects. So thank you very much for that excellent presentation. I would again request our participants to please type in your questions in the chat box, because we are running short of time. And I would like to hand over this time to Dr. Santosh Matthew as he takes us through the medical aspects of the COVID-19 response. Thank you.
Thank you, Priya. I also would request that panelists who have already presented, if they can look at the chat questions and respond in the chat itself, so that we can spare some time. Can you hear me?
Yes, we can hear you. There's a little disturbance, but I think it'll sort out, I think.
Yeah, we will listen from Dr. Prabhu first. Dr. Prabhu is an orthopedic surgeon, managing director of Duncan Hospital. Wife, Dr. Blessy, is a pediatrician. He has been my colleague and friend, and so I don't want to say too much about him. And many of you know, he's also the regional secretary of CMA in the Bihar region, Bihar Jharkhand region. Over to you, Prabhu.
Thank you, Dr. Santosh and Dr. Priya and Denison for this opportunity to share about the lessons from COVID wave. I'll just start my screen sharing. Yeah, so good evening once again to everyone, and thank you for this opportunity from Aruka Network and CMAI in giving us this opportunity to share about what we've learned from the last COVID wave. I bring greetings from Duncan Hospital. Duncan Hospital is based in Raxaul. It's a 90-plus-year-old hospital serving the people of the East Champaran district in this part of Bihar. And the COVID wave, like most of you all did say, hit us like a flood. This is a year-round feature that we face. You can see the flood waters flooding our OPD courtyard, and that's exactly what happened with COVID. One day we were okay, and next week we were flooded with cases, almost to the point where we were overwhelmed with the sheer number of cases. And overall, I felt that this year the spread was rapid. The infections were extremely infective. You know, you would meet a person. It happened to us. I personally felt it. One of my colleagues fell ill. 2 days later, I fell ill. Then another person fell ill. Before we could even isolate ourselves, most of us were exposed and infected. And we saw a much higher death morbidity associated with our patients. And sadly, a much younger age group of people were affected. Many young people came in with lots of problems, and many young people did die. And we were overwhelmed with the sheer volume of cases. You know, my phone number was given to the Motihari. My number was the point of contact for beds. And every day I was, flooded with calls asking me, do you have beds? Do you have oxygen? And sadly, I was just unable to help most of them. So the sheer volume of cases was huge. And most importantly, we were pretty unprepared. You know, I think Indians and medical health professional India were unprepared. There was warnings, you know, we knew that there's something happening in Maharashtra, but with the lessons from the previous wave, we assumed that this time it would not be bad, and it hit us. Overall, what did we do? We are a 200-bedded hospital and a multi-speciality hospital, but last year we had become a DCHC, and this year also we became a DCHC. That was one thing that worked for us. We've already had things in place, so we became a 60-bedded DCHC. This was run by 3 specialists, of which only one was an intensivist. The other 2, one was a pediatrician, one was a surgeon, who put in their services. And we had 4 doctors, 5 doctors, and about 40, 45, 50 nurses who pitched in their help. In this time, we treated about 275 plus patients, and we had about 40, 45 deaths. And there were huge numbers of patients who were positive, who had mild and moderate symptoms. And most of these patients whom we treated were actually severe. We didn't have time to treat, or we didn't have ability or place or the resources to treat everybody. So most of the time, the mild and the moderate, we ask them to stay at home or quarantine themselves and come to us when your saturation drops. Keep a pulse ox with you. Call me when your saturation drops below 90, below 80. That's how bad it was. So, but by God's grace, we managed to treat 275 plus patients. And though more than 60 of our staff were positive, but by God's grace, none of them, were adversely affected. None of them needed admission or hospitalization. Where did we struggle? I suppose one of the problems we struggled was with our staff getting very sick. When you have in the first week, both our physician and the intensivist fell ill, and I fell ill, and we all fell ill in turns, and when nurses fall ill, it's hard because you can't run the wards. So we had a huge problem when our staff fell ill. There was a lot of personal loss and tragedy. Many of us lost our loved ones, myself included, and many of us lost distant family, friends, and we were affected by that. And over the month that was May, we had tremendous emotional strain. I mean, I could see most of my colleagues just walking around with a depressed look on their face. They had worked on patients for weeks only to have to lose them in the end. And it took a huge amount of strain on our emotions. And everyone was sad, stretched out, and depressed. And there was a huge amount of lack of oxygen. I suppose all of us know that. We saw that in the media, we saw that in the news, and we had a few, we were a 200-bed hospital and we had about 40, 45, 50 oxygen points, but that was grossly inadequate to the number of patients that needed oxygen. And then the supply, we had a small puny 150 liter per minute oxygen plant, which could barely supply us adequate oxygen. So we had to depend on cylinders, which again were short supply, which had to be procured from a plant about 60 kilometers away. So, and the biggest hurdle was manpower shortage. My biggest fear was, what if our intensivist fell ill? What if the man who ran the show fell ill? How are we going to handle it? Because most of our patients were sick. At a time, most of them were on BiPAPs, on ventilators, on infusions, steroids. So it was a big fear. What would happen if one of them fell ill? And our nurses were short in number, but we did manage. And what really worked for us was that our staff were well prepared. We had gone through the first wave. So we knew protocols, we knew the SOPs, and they were a bit fearless, I would say. We were vaccinated. So that initial fear that we had in 2020 was not there this time around. So we had teams of doctors and nurses confidently come to the forefront. We had nurses who said that they would want to work in the COVID wards. That fear, I wouldn't say it's reckless, but it was a confident fearlessness that, okay, we are vaccinated, we can do this. And that worked for us. We had nurses and doctors. You can see the picture. That was a regular feature where everyone pitched in and turned the patients and took care of our COVID patients. We had a lot of infrastructure in place thanks to the previous wave. And we had a very good relationship with the local district admin. We had a direct link with the DM. And he was very much impressed with our work and supported us in numerous ways. I mean, I can keep on relating what all he did and what all we did. But we had a very good relationship.
Oh, yes, I do. Somewhere.
Yeah, we had a very good relationship with the local government. And he supported us.
So I think I put it.
Yeah. There was a lot of a positive support from the public because they knew, generally local public, they don't like us. There are a lot of problems and conflicts with them. But this time around, they knew that the hospital was doing something for the people. There were people working. This hospital wasn't shut and there were patients being treated. So we had a good support from the local public. And what to be thankful for was the tremendous amount of prayer support. We heard from a lot of people that they were praying for us, thinking about us, talking about us, speaking for us. And we received a lot of aid in terms of funds, in terms of equipment from within India and from overseas. And the sheer outpouring of help and many requirements were met one by one. I've listed what all we've received. A large amount of PPE, ventilators, concentrators, etc., etc. And it was a tremendous outpouring of love and things and prayer, which we were overwhelmed for. With in a time of struggle, friends and family and people who loved us poured out their help to us. And that's a picture grossly capturing the truck and ventilators, PPE and concentrators that we were able to receive. And what are the lessons that we did learn from this thing? I mean, I think the biggest lesson we did learn was depending on God, not backing off, being there, being the salt and the light, just being a hospital that had their doors open, that allowed people to walk in, to be cared. And I say genuine caring because many patients said that they liked what we did, doctors and nurses coming to them, touching them, turning them, that fear that they were not being ostracized, they were not being treated like outcasts. Many of them gave that feedback that in this hospital we felt cared for. They didn't treat us like outcasts. And God blessed us with a regular income. I never really did have to worry. Our income was good and God protected us. Like I told you, many of us turned positive. Many of us were spending days in the COVID wards. Many of us came back home, met from the wards, spent time with our kids. Many of us had parents at home, relatives at home, but God protected our community from any sort of harm. And I would say that was genuinely God's protection. And much like, Elijah and the widow, our oil and our flour never went dry. God kept providing. There was a time when we needed concentrators, it came. We needed ventilators, someone provided. We needed PPE, we could buy it, and we needed help. God just kept providing us with what we needed. And I'm so thankful to God for that. And another big learning that I had this year was the communication. We regularly spoke to the patient. There were a lot of misconceptions in between. The public said that the hospital is changing COVID reports and they are not declaring COVID on the death certificates, and there were a lot of misunderstandings. And there was a small uprising among the patients. It happens when one patient gets upset, it spreads. So we instantly spoke to the patients. We sorted out their concerns. We spoke openly. We spoke from my heart. I told them that we are here for you. We have lost our loved ones. We are struggling. We're not backing off, and we are here for you. And many of them did understand that, and that eased situation. Talking with the staff, we realized that many of our staff had fears, and we spoke to them. And many of us just being with the staff in the COVID wards, spending time with them, helping them. I'm not a physician, but I was there in the ward helping them, turn the patient or, say something or do something. And communicating with staff, we had videos, we had regular meetings, we had, we had a WhatsApp group on which we shared our voice messages and videos, reassuring and encouraging our staff. And the open line of communication which we had with the local government, that was amazing. I've never dealt with the government, but this was an amazing, I could just pick up the phone and call the DM and tell him, sir, this is the problem. And he would tell someone and it would get sorted out. So I felt this was a COVID wave was a time when we communicated with everyone, the patients, with our staff and with the local government. And a lot of importance for taking care of our team. I realized that our COVID nurses were doing it voluntarily and just being in the thick of things. And so we decided to give them an incentive, a small amount per week as an incentive, which I believe they were very happy to receive, because they, when you are in the COVID ward, you feel that I'm exposing myself to this, but the others are not being there. So that helped, giving them incentives, bringing them juice, bringing them refreshments, talking to them, encouraging them, and just being there. Like I said before, just being with them and managing cases with them made a huge difference. And many of our nurses, at the end of the day, wanted to be in the wards. They wanted to participate in the COVID care, which was amazing. And this time I felt help came from amazing quarters. Without us realizing, people, I would write 5-10 requisitions, and it would just, help would come in from the Aziz Premji Foundation, Tata, Boeing, and I mean, the list goes on. But so that opened up a lot of possibilities for the future. There are people willing to participate with us. In fact, the DM himself recommended a group to me who were willing to supply us with about 50 beds and ventilators and concerts. So I had to actually tell him, no, I'm sorry, we already have beds. Please do that to another center. So we had people actually calling and networking. So the lessons we could learn from this for the future are to reach out, share your concerns, share your needs, and help will come from amazing areas. As we look ahead, I hope we don't have this third wave, but we should be ready. And from my side, as Duncan, I hope that we would be able to manage with the oxygen. So by God's grace, we are piping all the beds. We are putting oxygen outlets in all the beds. We are planning to get 30 cylinders, buy 30 cylinders instead of borrowing it. We have been promised a 420-liter oxygen plant. By the 25th of this month, by God's grace, it would come. Beds, we have purchased 8 new beds, prepared our wards. Of course, we have enough PPE. So we seem to be well prepared, and I just hope that we don't need to use these equipment. Of course, a lot of prayer support and trusting God to take us through the storm. I think if you depend on yourself, you're going to fail. And I've learned that this year, much like how Elijah and the widow received what they wanted every day, God gave us what we needed through this last wave. And of course, investing in people, it's always a shortage. You know, how I wished I had 3 anesthetists, how I wished I had 3 physicians, how I wished I had another 50 nurses. We could have saved so many more lives. All we needed was, we had the beds, we had the equipment, and the next wave, if we could treat 200 COVID, we can. But with just 1 anesthetist and 1 physician, I don't think that's going to be possible. So people, yes, a huge need for the future, but I leave it to God. I hope that He would hear our cries and He would send us people. So thank you for listening to this, and thank you so much.
Thank you, Dr. Prabhu, for that. I can't call it a presentation. I think it's sharing from your experience and your life, and I think very important lessons. You know how in the challenges you saw God and the community coming together. Of course, it's a lovely. Somebody has written, it's a lovely story of God's grace and provision. At the same time, I think there are medical lessons. It's a very infectious, very virulent, affecting the young. I think that has been the pattern. We still don't have the data. Since we are running short of time, I'm going straight to Alex from NIEA. Alex is the director of NIEA. It's in Purnia, Bihar. It's a 100-bedded rural hospital. We were together in Louisiana back in 1980s. Over to Alex.
Thank you, Santosh. Good evening, everybody. I have good news for you. My presentation is really short. Thank you for being with us on a Friday evening when most of us should be at home. But I will make my presentation very short and succinct. Thank you very much for joining us. I live in Purnia, Bihar, and also coordinate national work with about 800 staff in 10 states of India. I've been asked to speak about some of the lessons that we have learned. One of the things that is obvious is emergencies happen quickly, and being prepared is so important. In the possibility of a 3rd wave, I think we need to learn lessons from what we have experienced. In talking to a friend from Germany yesterday, he said that they were preparing for the 4th wave. And last evening's paper says that Singapore has started to issue guidelines that they will live with the coronavirus for a long time. So who knows? We are into perhaps a few more waves as we move forward. My core reflection is just these 2 points. Number 1, being alive is a gift. After about 90 days of working in the wards, I really think that just being alive is a gift. The fact that God spared us, and as healthcare professionals being able to serve, it is really a calling, and therefore using life wisely and serving it, as Prabhu said, being the salt and the light is so meaningful. Wealth is of low value when compared to the immense riches of deep and meaningful relationships with family and friends and community. And I hope we can continue to be a community who love one another, care for one another, and support one another. Setting the stage of where we are and what we did In the last few months, the number of patients treated, about 1,754. The number of inpatients that were with us were about 128. The average duration of stay was not 6, but about 8 to 10. The average cost for inpatients was about 33,000. The average cost of medicines for both IP and OP patients was about 2,500, and so on. Almost everybody who came to our hospital said they had another patient at home who was affected. Here is Hajra Khatun, a 42-year-old lady, mother of 4 kids, came to us COVID positive, viral pneumonitis, and with saturations below 80. Unfortunately, she developed cardiac complications as well. And I remember talking to her husband one midnight after rounds and telling him that we were battling not only respiratory distress, but also cardiac problems. And he lifted up his hands and said, "Only God can heal her. Only Allah knows what will happen to my 4 children." And he started to weep. 26 days later, she was wheeled out of the critical care, and she walked home just like many others walked out of the hospital, healed, knowing that God touched them, and because of that, they are well. Some of the lessons that we learned was the unpredictability of this disease. We were not sure who would actually make it to the discharge door. We had patients falling ill on the 8th and the 9th day and had needed to be referred on. So there was a lot of uncertainty about who would actually make it. This was also a wake-up call for us in healthcare to be mentally, spiritually, physically, and emotionally vibrant. This was obvious to us as we looked at patients. Many of them were in poor physical condition. And so it was a reminder for us in healthcare that we need to maintain our own condition, mental, spiritual, physical, and emotional condition. The lesson that we learned, I echo what Dr. Prabhu has shared, caring for the team is so very important. Being considerate, giving them incentives, giving them extra food, being caring towards their needs, especially emotional care. And working together with different departments of the hospital, healthcare providers, whether it's the admin staff or the finance staff or the cooks or the drivers, everybody had a role to play. And working together as one team, I think, is the way forward. And as our friend from World Vision said, prevention is better than cure. The SMS, sanitize, masking, and social distancing, I think this is so very important that we continue to prevent, continue to inform the community that SMS is important and move forward in that way. I only want to say that to us, in a small hospital, we were asked to have 20 beds. We were very short on oxygen very often. God gave us enough at the right time. Madhepura helped us. That was wonderful. We never had to turn away a patient because of lack of oxygen. But in preparation for the 3rd wave, it seems that oxygen supply is absolutely mandatory. And whatever we can do to increase oxygen supply, whether it's cylinders, whether it is plants, whether it's equipment, all of these things are important. A summary of the areas that we need to be prepared for is oxygen supply, healthcare infrastructure, diagnostic products and services, medical devices, personal protective equipment, training and capacity building of healthcare workers, information, education, and communication for behavior change. So these are the lessons that we have learned. These are the ways, the 5-7 areas that we are working on even now as we prepare for the 3rd wave, and hoping that these will become sustainable areas of development for the small hospital that we are here in Bihar. Thank you very much for your time. God bless you.
Thank you, Alex, for that short and succinct and very sweet presentation. Maybe there's much more than what he said. There is much more. Thank you for that. Due to lack of time, we are just kind of going to conclude in a couple of minutes, 5 minutes time. I think most of the questions put in the chat has been answered. So if you have need any more clarity, please look. There was one question about if anybody has information, please put it. Just concluding the hospital section, both Ashish and Prabhu's and Alex's presentation, I think one thing which stood out was the response of the staff. I think this pandemic has really brought the Christian compassionate care to the forefront. The staff stretching in the middle of their personal pain, caring in the midst of personal pain, staff willing to reach out in the midst of all the personal other challenges they're going through. The other is the dependence on God and how God opened up doors and opportunities and the resources. It was very encouraging to listen to that. Of course, in the midst of all the uncertainties and the virulent pandemic and many deaths, and I just want to thank God for each of this healthcare workers who are in the forefront doing excellent work at the cost of their own physical, emotional, and mental challenges. Priya, you want to conclude with any other comments? Otherwise,
just to say again a thank you to all the panelists and a quick summary of the community aspects. We heard from a person who's been involved, Dr. Narottam, with the NRLM, the GVK, all very good flagship programs looking at social safety nets for the community, and they have proved to step up during this time, but also looking at how people can actually access it, and that would be a very important role of the community health workers. Resilience being the main outcome that all of us would like to achieve. Taking away the panic, the fear, the stigma which is still there in the community is another area which we need to focus with sensitivity and a good strategy. Looking at a hospital-based community service with the full continuum of care available, I think that's a huge advantage that can be taken care of and which can be a good support for the government for all their programs, not just for COVID, but to keep all their healthcare programs, national programs in line with their deliverables. So just to conclude, as we look at post-COVID scenario, a lot of things to keep in mind and not to take anything lightly, especially when you're looking at post-COVID building up as well as COVID appropriate behavior. And this is something that the communities can do and the workers there can do it really well. We always say that the community health workers will know names. Maybe in a hospital you have numbers, but in the community we have names. And those are the names that we will care for and ensure that they have the holistic care available to them, both in livelihood as well as in healthcare. So thank you very much to all the panelists. I hope some more questions can be answered on the chat itself. And I would now like to thank again Mr. Dennison and Aruka, and also all the donors who have been very kind to our mission hospitals. I'd like to especially thank Action Aid, and if representative Mr. Saurav is here, to thank him also very much for all the help and extended. Over to you, Mr. Dennison.
Just close in prayer. Maybe just thank God for his, his presence with us through this wave. Shall I ask Dr. Ashok to close in prayer? Dr. Ashok, can you hear me?
Yeah. Yeah, I could hear you.
Please, will you close in prayer?
Yeah, thank you. Our loving Heavenly Father, thank you and praise you for this wonderful evening. Thank you, Lord, for helping us to learn and reflect back the community side and the medical side together, and what we should go, what should do in the upcoming days, Lord. And especially we thank Dennis Anand and Dr. Santosh Matthew and Dr. Priya ma'am for all their effort to put forth to help us to learn and to reflect back, Lord. And we commit all our mission hospitals into your hand. Thank you, Lord, for guiding us, each team, to venture the different things in this area so that we could be a blessing to the people around us, Lord. And we believe and we trust that in the upcoming days you would fulfill for the purpose for which you have called and to make us a blessings to the people around us. In Jesus' name we pray. Amen.
Amen. Thank you so much. Thank you for being here. We know we had very little time for discussions. If you want to do another meeting only on discussing things, maybe you can message us. We can see how we can do that. Thank you so much. Thank you, Dr. Priya. Thank you, Dr. Santosh. Bye.
Thank you all.